COVID series. Special thanks to our collaborators with the Hawaii Emergency Management Agency, Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, HAMDA, and Mountain Pacific Quality of Health. At this time, please enter your name in the chat box for attendance purposes. And if you are calling in on the phone, take a moment to type in your name if you can, if you have a smartphone, or unmute yourself and tell us your name, and then we could write it down. Okay, next slide. Okay, just FYI, this is the schedule. Today, actually, we're going to cover our agenda kind of changed a little bit. We were going to talk about some lessons learned in nursing home outbreaks, but they're kind of overwhelmed at this point with that. So we're actually going to talk about something a little more relevant, actually, even. We're going to talk about the CMS nursing home testing requirements. And then for the first half, and then at the second half, we're going to talk about lessons learned in the care home outbreaks. And then next time, that would be September 16th, we're actually going to talk about how to accurately report COVID deaths, because unfortunately this is a reality and we need to know how to report them accurately. Okay, next slide. We will be offering CMEs. And also certificates of attendance. If you haven't already registered, we encourage you to do so after this webinar. There is a link on the website, as well as it will be in the chat box as well. Next slide. We have a number of resources on our website, so I would encourage you that when you get onto our website, you can get the flyers for Here on the Job. And we actually just posted a new PPE resource document. We just updated a bit yesterday, so please take a look at that and share that widely. We have just some other important things like what to expect if there's a case in your facility, first things to do as soon as you get a case, so you can get started even before DOH gets on board. We have stuff about the Patel decontamination system and contact tracing. So lots of really good stuff, resources. Next slide. Also want to point out additional resources for the community at Mountain Pacific Quality Health. There's a nursing home quality improvement resources and tools, and you just go click down there. Next slide. Okay, so this is a late-breaking announcement. There's this new initiative, and maybe people have gotten emails about this. This is the National Nursing Home COVID-19 Safety Program. So this is actually initiated by the ECHO Institute at the University of New Mexico, and in collaboration with AHRQ and IHI and the UH Department of Geriatric Medicine, Mountain Pacific, and HAH, we are joining forces to try to see if we can put this on here. So what this is a training on addressing COVID for nursing homes. What it includes is COVID-specific material, as well as mentorship from IHI regarding implementation and QI efforts. There is a 16-week commitment and subsequent consultation for up to a year. These are 90-minute sessions for 16 weeks, and about 2 to 4 staff are invited to sign up. There is at least a $6,000 incentive for nursing home participation that you can use to purchase PPE testing, or PPE or testing or whatever is needed, equipment. And in addition, apparently there are about $2 billion of federal incentive money that have been appropriated for nursing homes based on performance, and that this sort of curriculum is helping you gear up to get this incentive bonus for performance later on. And so I just wanted to encourage you to sign up for that. Let us know, send us an email, and let me know if your facility is interested, and we'll get back to you. Basically, whether the program runs or not is contingent on how many people sign up, how many facilities sign up. We need to have a critical mass to make it worth it. So, so I just wanted to let you know that. Okay, next slide. I also wanted to just mention to you that I was just on the ECHO call from at New Mexico they just put on this morning, and they talked about an example of a statewide organized effort in Massachusetts, the Massachusetts Senior Care Association, and they shared some really exciting things that they did in their state, and I think basically what they did there is what they're trying to use as a model to sort of replicate, on a more wide-scale basis with that ECHO program. So basically what it was a statewide effort to implement best practices. They did weekly educational webinars with PPE staffing and checklist items. They did on-site assessment and consultation, an assistant with an action plan, and then weekly Q&A with the Department of Public Health. And what all of these efforts did is that resulted in significant reduction in new residents' infections, staff infections, hospitalization rates, and mortality rates. They did the assessment by audit surveys and looked at their rates. They had looking at percent adherence to a checklist and percent adherence to core competencies, and resulted in a decline of weekly rates down to 0% in a lot of cases after about 5 weeks. And that was all adjusted after county prevalence. And we know Massachusetts had a pretty high prevalence as well. And they went from really high to they pretty squashed it down pretty fast. And they also, as part of that program, rewarded by incentive payment for percent adherence. So anyway, if that reminds you of anything, that's kind of what they were looking at. This is Lou Lipsitz. Dr. Lipsitz is my mentor over at Harvard when I did my fellowship program. He just got this article published in JAGS Accepted this week. Anyway, so I'm going to reach out to him as well and try to see what kind of stuff I can learn from him. But I just wanted to let you know, and that I'm actually really proud of our state because it looks like we've done a lot of these things as well. So anyway, I just wanted to throw that out there and encourage you again to let us know sooner rather than later whether or not you're interested in this initiative, and that way we can decide whether we can move forward or not. Okay, next slide. I think that's the end of that slide, right? Okay, so if we can just pull up the next PowerPoint. So I just wanted to introduce, so we're going to cover a lot of stuff, as I said before. We're going to talk about the COVID testing. Patrick Harrison at HIH is going to get us started there. And we have a couple of other folks on the line here, which I'm hoping on is going to help us answer some of our questions, including Keith Ridley and Sarah Kemble and Al Yazawa, all those guys. So thank you everybody for joining here, because I think it's together we're going to have to do this together. So anyway, let's get started with that.
Thank you, Dr. Nguyen. Appreciate all your efforts on this. And good afternoon, everyone. For those who don't already know me, my name is Patrick Harrison. I am the Senior Director of Post-Acute Care at the Healthcare Association of Hawaii, HH for short. HH is a nonprofit trade association representing over 170 providers here in the state of Hawaii. It includes all of Hawaii's hospitals, nursing facilities, home health, hospice, and many of our assisted living and type 2 adult residential care home providers, among others as well. I would first like to express my gratitude to all of you just for the incredible work you have done and are continuing to do during the course of this pandemic. We understand just how challenging this is, and this is a marathon, although now it seems more like we're sprinting. So again, thank you for all the hard work you're doing. With that, we'll go ahead and provide an update here on what's going on here with this new CMS rule, as I'm sure many of you have questions about. Next slide, please. So last week, August 25th, the Centers for Medicare and Medicaid Services, or CMS for short, did issue a final rule which touches on a number of provider industries, but for the purpose of this call, addresses a new testing mandate for skilled nursing facilities. Now, skilled nursing facilities are only ones covered under this testing rule. This does not apply to assisted living, ARCHs, foster homes. It only applies to Medicare, Medicaid certified nursing facilities. What this rule does is that it amends conditions of participation and particularly infection control requirements to require testing in facilities for COVID-19. Now, again, I apologize for the organization of the slide here. I'm just going to move around a little bit here, but what this essentially does is that, and I suspect many of you know this already, is this does require testing of staff and residents under different criteria. Now, I do want to briefly touch on staff. Again, I'll talk about this a little bit later in this presentation, but staff is a very broad term. Staff also includes any contractor, any individual consultant, person who's providing services to residents at the facility, either on behalf of the facility or under arrangement with the facility. So facilities are also responsible for ensuring that these, quote, staff are covered under this testing as well. Now, this does impose enforcement sanctions for facilities, and there are some pretty steep penalties here for failure to comply, which we'll touch on a little bit later here. But I do want to note this rule is now effective today, September 2nd. Next slide, please. Now, again, I'm just going to give some high-level overview, a high-level overview here, and I'll touch on the specifics here later. But in short, this requires testing of staff and indeed residents under certain criteria. Now, one thing I want to note on now, and I'll touch on a little bit later as well, is that as I'm sure many of you experienced, not all staff and residents will consent to testing. You can't force residents and staff to consent. There very, very well may be situations where they just flat out refuse or don't want to get it and so forth. So CMS certainly recognizes this, but this is in itself not an excuse to not handle these situations. I do want to note that you should have policies and procedures in place to really address these type of situations. On top of this, you really have to take steps to ensure that you continue to safeguard your resident and workforce populations for situations where residents or even staff refuse to have tests conducted as part of these mandated efforts. It may include limiting staff's access to the facility, specifically in outbreak situations where a case is confirmed. Then that staff should be restricted from coming into the building until all the outbreak testing procedures have been completed and, generally speaking, have been cleared. The same goes for residents. If there are residents who refuse testing, generally speaking, that should be put on transmission-based precautions, treatments PUI, and also it's up to the facility to ensure that these residents are kept away from others and minimize any risk for cross-contamination or transmission of COVID-19. Next slide, please. Now, again, I'll go over this a little bit later, but at a bare minimum, Medicare, Medicaid nursing facilities will be required to conduct testing of staff. This could either range from once a month to twice a week, depending on the facility's county testing positivity rate in the prior week. There's a link there on the slide here for those following along here from CMS. Again, this data does not come from the Hawaii local health department, does not come from anywhere else. You have to access this data from the Centers for Medicare and Medicaid, CMS's nursing home COVID-19 website, with the link there's on the slide. And you again have to look at the preceding week to confirm positivity rates. Facilities should also check here every other week just to stay on top of this testing positivity. Also, in terms of testing, again, any antigen device that's accepted under according to its medical standards of practice, generally those that have at minimum received their emergency use authorization of the FDA. And again, also recognize that PCR tests will suffice for the purposes of testing. I do want to note here that antibody tests are not permitted. Now, these are not diagnostic tests and may not be used here to satisfy testing requirements. Next slide, please. Now, earlier I mentioned 3 triggers for testing, and I do want to touch on these very briefly. The first of these is symptomatic testing. So any resident or staff member in a facility that has developed signs and symptoms consistent with COVID-19, that individual should be tested. Again, if they refuse, then follow your appropriate procedures and make sure you document your efforts and make sure you document your protocols here. And as I'll repeatedly say throughout this presentation, documentation is going to be critical in your efforts to comply with this new mandate. Now again, symptomatic residents or staff, that does not require facility-wide testing. It's only of individuals who have signs and symptoms consistent with COVID-19. The second category is when you have an outbreak in a facility. Now, as you and I think of outbreak, we think of a widespread infection. But according to CMS, outbreak refers to a single case that occurs in the facility, generally speaking within staff, or that is nursing home onset. Again, what this means is that testing should be conducted of all staff and all residents in the facility after a nursing home onset or staff-confirmed case in the facility. This testing should be repeated every 3 to 7 days until there's been a period of 14 days since the most recent positive result. Now, as I mentioned earlier, there will be situations where staff or residents refuse. Again, follow appropriate protocols for that. But I do want to comment here that this only refers to nursing home onset. This will not penalize nursing homes who set up their own COVID units or admit COVID residents into their facility. Again, this only applies to nursing home onset. And what essentially, again, this does not apply to residents who have COVID-19 and are admitted into the unit, or who are residents who are placed on transmission-based precautions on admission and developed COVID-19 within their 14 days of their admission. The final category is routine testing of staff. Now, again, I just want to note here, this is routine testing of staff, not residents. CMS does not actually recommend testing or surveillance testing of residents at this time, especially asymptomatic residents. So this is just routine testing of staff. Next slide, please. Now, as I mentioned before, this is routine testing of staff is going to be based upon your county's positivity rate. And by county, I mean the county in which your facility sits. Low prevalence, or for less than 5% positivity rate, this is going to be testing of staff once a month. If you're in a county with a 5 to 10% positivity rate, be once a week. And finally, for counties with higher than 10%, this will be twice a week. Now, as I mentioned before, again, you should monitor your county positivity rate every other week. For example, looking the first and third Monday of every month, and adjust the frequency of testing in accordance with your county's positivity rate. Now, we know this is complex. We know this is challenging here. We're also monitoring this data ourselves, and we'll be providing this update to our member facilities here at HAH. But again, it's something important to note. And I also want to comment here as well. Make sure you document your county's positivity rate when you conduct your testing. Again, as I mentioned before, and I'll mention again, documentation will be critical. Next slide, please. Now, this just shows the positivity rates according to that CMS website. I believe it's the dates August 13th and 19th. So as I mentioned before, this CMS rule goes into effect today. It's now active. So this is the data, at least for this week, which you will use to base your testing. In other words, Honolulu County nursing facilities, again, Medicare, Medicaid certified facilities only, will fall within the 5 to 10% bracket, which means once a week testing. Neighbor islands, once a month at this point in time. Again, this very well may change, but at this point in time, this is the criteria you'll be utilizing. Next slide, please. Now, I've repeatedly said documentation. Again, I don't mean to hound this, but this is a really important point here. Is that, when you conduct your testing of staff, residents, and population, you need to adequately and sufficiently document your testing efforts. This includes documenting the date, the time, and specifically if you identify symptoms and signs, you should document those when those were noted. You should know when testing has been conducted. You should also document your efforts to obtain testing. Communications with labs, or if you're using an antigen device within your facility, document those protocols, and also document when the results were obtained. And also should include any follow-up action you took as a facility in response to those results. Now, one of the criteria here, or one of the caveats, is that in terms of testing, CMS has imposed a quick turnaround time of testing results. So when you work with lab partners, when you conduct antigen testing or so forth, you should work with a lab that can provide test results within 48 hours. I'm going to touch on that again, but that's going to be critical. Same thing, again, documentation is key when you identify a new COVID case. Much of the same information, dates, times, actions taken, efforts taken, and the results of all tests. Now, as I mentioned before, for routine staff testing, again, this does not apply to residents. Routine testing only applies to staff. As I mentioned before, document your county's positivity rate. You don't want to get cited on this. This is an easy point to note, so make sure you document that. Also document the frequency based on your positivity rate, the date the positivity rate was collected, and a date that was performed for staff. And again, through in line with this, document your efforts, document protocols taken, etc. This is going to be critical. As I mentioned before, document efforts for any residents and staff who refuse testing, and also document what your follow-up actions were in response to those situations. Now, finally, and I mention this point because this is going to be critical as well. If you run into challenges as a facility in accessing testing supplies, test kits, devices, working with a lab, document your efforts. And testing shortages, this is going to be critical to ensure that you do not receive citations or do not get cited for your failure to comply with this rule. I also want to note here is that in addition to working with your lab partners, you must also reach out to the Hawaii Department of Health. You have to do both. You can't just work with a number of labs, you have to work with both. If you can't reach your normal supply chains through your lab, again, or through your antigen testing devices, reach out to the Hawaii Department of Health for any assistance that they may be able to provide, and document those efforts. Next slide, please. Now, I mentioned earlier about testing. Again, these do have to be acceptance tests. They must generally be standards that have been accepted by the medical community. Again, at minimum should be generally those who have received emergency authorization. And the standards apply the time that the care and services delivered. And as I mentioned before, turnaround time is key. 48 hours is the deadline. Again, I mentioned some of this already, so I'm just going to glance over the slide here. Again, another key important is, again, we mentioned recording here, but it's critical both to record test results and also it's part of the fact that particularly for those who have their CLIA certificates of waiver and have their Hawaii clinical lab permits, which is I believe most of our facilities here in Hawaii, you must also report these test results. Now, right now, for any positive test result, even with an antigen device, you need to report that immediately to the Disease Outbreak Control Division. And I apologize, I didn't put a number on the slide. We can certainly provide that information to you if you have questions. But again, that's an urgently reportable condition. So any positive test result, call Department of Health immediately to report that result. In the aggregate, make sure you document all of your negative results. That's going to become later down the line with reporting in the NHSN, the National Healthcare Safety Network. And there is a 3-week grace period we provide to begin reporting test data. I think, Dr. Nguyen, I think that's what you're referring to earlier. Now, there are, again, penalties for failure to comply here. That includes civil monetary penalties, or CMPs for short, $1,000 the first day, and $500 for each day following that. So these are some pretty severe penalties, which again is why I'm hammering home the need to document, the need to really address these protocols. Next slide, please. Now, we've said in previous calls, and I know many of you have already been working on this, is that the need for an effective testing plan. And it's vital that facilities have a testing plan in place to respond to COVID-19 protocols or to situations where COVID does occur in the facility, and how and when you will conduct testing, be it working with a lab partner, be it working with an agency that comes in directly to the facility to conduct this testing and do swabs, or yourselves. So again, it's important you have a testing plan in place, that you address these and other protocols. And also, this goes into ensuring adequate testing supplies and arrangements are specifically how you plan to obtain these supplies. And that also should be addressed by your infection prevention and control plan. Now, this is not news to you, and many of you, COVID has been increasing in our community. Unfortunately, many have had to deal with this already. But for situations where residents test positive, you do need to have procedures in place to address these protocols, isolation, cohorting, et cetera. Also for return to work criteria as well. Again, the Department of Health has published medical advisories to help answer some of these questions. Now, we know staffing has been a critical issue for many of you. And I know this is going to be easier said than done. I do want to note that in the rule, it's ensure to have contingencies in place and strategies to how you will address staffing shortages. We also know that staffing is there will be significant labor costs to try to comply with this testing requirement. Again, document efforts here, documentation is going to be key. There's also some resources there on the slide as well from the CDC, or excuse me, my apologies, they're both the CMS and the CDC resources there for staffing shortages and contingency strategies. Now, I mentioned earlier about NHSN reporting. Again, there's additional information here. It's important you will get cited for failure to comply with this reporting requirements, results in F level of citation. And again, the penalties get pretty severe, starting at $1,000 and going up in $500 increments from there. I do want to note that this is that penalty period actually extends beyond even the federally recognized public health emergency, and it goes beyond 1 year beyond that point. So again, it's important you really stay on top of this. You don't already, if not already doing this, and I believe again you all are doing this already. Just have protocols, work with staff to make sure you're on top of it. It's an easy citation, easy thing to avoid. Don't want to get cited for that. Next slide, please. Now, this is, again, according to the language here, this is why I mentioned the importance of documentation. If you have documentation that demonstrates your efforts to comply, obtain testing with the guidelines, again, which also includes outreach to the Hawaii Department of Health and efforts to work with laboratories to obtain testing within 48 hours. Again, 48 hours is key here. You should not be cited for non-compliance. But again, this is contingent upon you having sufficient documentation and having taken sufficient efforts to comply with this rule. Again, this is easy to get, just don't want you to get cited here. We know this is an extremely challenging mandate to comply with, and there's going to be many growing pains with this. That's why it's really important here, document your efforts, make good faith attempts here, document, document, document. Next slide, please. So what does this mean for Hawaii? Well, what does this mean for us? Again, Hawaii is one of the few states that, generally speaking, have not mandated testing nursing facilities to this point in time. That goes with the fact that we've been very successful as a state in mitigating the spread of COVID-19. And generally speaking, we haven't seen the prevalence that other states have had to experience several months or several weeks ago. But now again, we are seeing this mandate coming from not at the federal level, and we're now beginning to catch up with what other states were experiencing. This understandably has resulted in many questions and many concerns with how to comply. First step, mentioned earlier in the call, you need to determine what the testing frequency is for your staff. Again, so routine testing only applies to staff, not residents. As I mentioned earlier, right now at this point in time, and this may change, for Honolulu County nursing facilities, that is once a week. For neighbor islands, that is once a month. That's the first step. Second step, establish a testing source. Many of you have received antigen testing machines from CMS, although not all of you have received those. I know many of you have already. But it also is incumbent upon you to work with, make arrangements with a lab partner to supplement and secure any testing efforts. So again, you must have a testing source in play. It's helpful to have multiple testing sources in play, particularly on the basis of the fact that antigen test results, as we all know, they have, generally speaking, they are less sensitive than your molecular PCR tests, meaning that in situations where COVID is suspected in a patient, but the antigen test result shows negative, you should follow up with a PCR test in those circumstances. That again is going to mean that you may need, you will need to make arrangements with labs to conduct testing and supplement your efforts here. And as I mentioned earlier, there is a 48-hour result requirement. There's also labs, there's both labs here in Hawaii, clinical labs, DLS labs. Many of you already have arrangements with them. Would encourage you to continue to reach out with them if you have not already done so. Work with them in your lab arrangements, assess what their capacity is for you folks, and to make arrangements to going forward. There's also a number of opportunities here to work with labs on the mainland. We've been reaching out to several of these, and there's a few that are able to provide, are reported being able to provide test results to Hawaii nursing facilities within 48 hours. We sent out some information to our members on that, and we will be following up later as well with some more information. Next, I want to touch on policies and procedures. This is going to be critical here, that you have policies and procedures in place as to how you're going to comply with this monolithic mandate. Again, we know this is a huge ask of you, a huge mandate. We know there's going to be huge growing pains. It's really going to be incumbent to ensure you have policies in place to address these. To better support you, we are looking at a number of opportunities available here to see if we can find some type of templates or some type of resources to support you in these efforts. Again, we know this, we know we need all the help we can get here, so we're doing what we can to better support you in this. But again, policies and procedures, it's going to be key. It's required to have this part of the rule. Don't want to get excited, ensure you have them in place. And if you haven't already started working on them, make sure you get that started really soon here. One of the most important things I do want to touch on as well is training. It's absolutely vital to ensure you have staff trained to go along with this testing mandate. And this is a huge monolithic effort here. I know a number of you made arrangements with outside lab entities to come into the facility and perform swabs. Some are having staff do it themselves. However you do it, it's important you have appropriate training for staff, and not just with direct care staff who may be providing MC swabs. Any person who's involved in this effort should receive applicable and appropriate training. Now, tomorrow there is a Department of Health and Human Services webinar. That is at 6 a.m. Hawaii Standard Time. Facilities who have received antigen testing kits will have received this information. There is a registration there, and that's an opportunity to hear from both cont'd Sophia and BD Veritor, the two antigen testing devices that facilities have received here in Hawaii. There's also, again, interim guidelines posted there on the slide here for collecting, handling, and testing clinical specimens of COVID-19. And again, it's important you find ways to conduct this training, which also includes in-service trainings for the staff. Again, it's important you have effective and comprehensive training and education for your staff to reinforce these strategies. Now, I've been speaking to different facilities and associations on the mainland as to how they've accomplished these efforts. Some facilities have established test or specimen collection champions. I use champions on term, generally having staff members who have been specifically trained to do this, work with receive additional training, and work collaboratively with the facilities administration to collect these swabs and conduct this, get these results. Now, I understand this is going to be logistical challenges. Staff work at different times. There are multiple shifts here. Again, some facilities use 12-hour shifts, some use 8-hour shifts. There's evening shifts, there's weekend shifts. So this is going to be a very real logistical challenge trying to coordinate this, this testing of staff. Again, training is important here. Work with the staff willing to do this. Try to come up with ways your facility can effectively accomplish this. And again, document your efforts and have policies and procedures in place. And finally, testing orders. So again, generally speaking, that's generally to require orders. Maybe helpful to look at getting standing orders, working with your medical directors, whatever's pertinent, and in collaboration with your medical team here to get these tests for your residents and your staff. Next slide, please. Now, again, we covered all this already, or much of this already. I just want to reiterate, for antigen testing, again, to perform antigen testing, that means you must have your CLIA certificate of waiver at minimum and a clinical lab permit under Hawaii law. If you haven't already, verify these requirements for conducting antigen testing. Make sure you're complying with this and any reporting requirements here under Hawaii. Again, we mentioned earlier, any positive test results should be reported immediately to the Hawaii Department of Health Disease Outbreak Control Division. CDC has also recently released guidance here, interim guidance on antigen testing. There's a link there on the slide. There's also specific guidance for nursing homes as well, or antigen testing in nursing home. Would encourage you to look at that if you have not done so already. As we mentioned before, review your reporting requirements and really establish a recording and reporting process to streamline this events, ensure you have a process in place to address this going forward. Now, this rule is in effect for the duration of the public health emergency period. So this very well likely will be with us for some time. So again, right now we are running a marathon here. You do need to have procedures and means, processes in place to address this going forward. I mentioned training before. Again, training is going to be critical here. The cont'd, there's a website there with their own resources, and BD Veritor website there. And as I mentioned earlier in the call, include this testing efforts in your infection prevention and control program. With that, again, that's all I have for you folks. I do want to pause and I defer back to Dr. Nguyen here if any comments or questions we can hopefully to address.
Okay, so I'm sure you have like a million questions. So, and I know we're not going to be able to address everything. So I'm going to ask you to, whatever questions or concerns you have, please just type them into the chat box. And whatever we don't cover, which I'm sure is a lot, we will try to take it up to DOH and HIEMA and all those guys and HAH to try to help assist everybody, because we know this thing just fell on us from the sky, and that we need to help each other comply with this, because we don't really have much of a choice. With that, I just wanted to just give a couple of seconds, a minute or so for Keith Ridley to comment a little bit, because he's from the survey department there. And then after that, maybe Sarah Kemble could maybe have any comments that she wants to share. Go ahead, Keith.
Thank you. Appreciate it. Appreciate all of you being together on this call. And just to reiterate what Patrick was saying, he stressed many times to document, 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 and I can't stress that enough as well. And I apologize for being late on the call, and I apologize for being interrupted just the last few seconds ago on the call. But I believe he also talked about policies and procedures. Make sure that your policies and procedures reflect what you're going to be doing and how you're going to be requiring testing or offering testing, and then follow those policies and procedures, because that'll be very important too when our surveyors go out and conduct recertification inspections at healthcare facilities. So, we're going to work with you as best as we can. We've in-serviced or are in the process of in-servicing our surveyors on what the requirement is from CMS. We're also working with our leadership to identify any monies that might be available to help with the cost of testing, and we hope to hear something very soon on that. But I don't have anything for you at this immediate point. So we're trying to do everything we can to assist all of you in this effort. We'll take it a day at a time at this point, and we'll resolve any other problems that are unforeseen. But until that time, again, I appreciate all your forbearance. I appreciate everything that you folks are doing on behalf of your residents and on behalf of the community, and I encourage you to keep up the good work. Thanks a lot.
And in terms of comments from DOH, from the Disease Outbreak Control Division, the main thing I wanted to point out right off the bat was just the interim guidance on specimen collection. Also notes shipping instructions, but they're kind of specific to shipping specimens to CDC. Just a reminder to everyone, of course, if you're here in the state of Hawaii and you need confirmatory testing on a specimen, please do contact Department of Health here before you contact CDC. And if we did have any requirement for CDC testing, we would help coordinate that. But again, our disease reporting line is 808-586-4586, and that would be your first stop number for questions about confirmatory testing on specimens.
Great, thank you. Okay, wow, that's a lot. So anyway, so I know that we really don't have a lot of answers, but I know that everybody is going to try to pull together in the next week or two and try to figure out how to better support nursing homes in a mandate that is impossible to follow. And we try to dig around as much as we can to see if there are any other ways around this, but it doesn't look like there is. It is an interim rule, and there was a comment period, but it looks like they're just pushing this forward, implement starting today, even before the comment period is over. So I know that AMDA has put out a statement as part of the comments, and there's a lot of other concerns regarding, how good the test is, the sensitivity, specificity, whether it's cost effective, and all those, really important questions. But, unfortunately, the federal government's just going to go ahead with this in the meantime, before waiting for comments. So hopefully they'll revise later on. But for now, I think we all have to just plan on following these rules. Okay, so you can continue to type questions in the chat as we go along. I wanted to make sure we had had the opportunity to have our other guests here on the line speak to us. We have Curtis Toma and Audrey Suga Nagasawa, and they're going to talk a little bit about some lessons learned in care home outbreaks, because we've had a number of those here as well. So I'm going to just let them share a little bit.
Thanks, Ida. Can you hear me okay?
Yes.
Okay. I just have 6 bullet points that I wanted to go over, and I don't know if you got the slides or not, Ida. If not, I'll just go over the bullet points and send you the slides later. For long-term care, we have the nursing facility. We also have the community side. For Medicaid, we have, on Oahu, we have 2,600 patients in foster homes, and versus, nursing facilities on Oahu total has about 2,800. So we have about the same amount of beds in Medicaid foster homes as all the nursing facilities on Oahu combined. Now, those patients are all the same ICF SNF level of care. For example, for Medicaid, we apply a 1147 tool to the patient. If they meet level of care, then we give them a choice between nursing facility like Halinani or a foster home, among other choices. But today we're talking about lessons learned in the foster home setting. So the first kind of bullet point, probably the biggest point that we learned was you have to go upstream on the cases. By far the biggest thing is you have to go upstream on the cases. So when the first case that we learned about in the foster home was a couple days after Dr. got the results. And then in subsequent cases, we got to go a couple days upstream where Dr. would flag us on the case as soon as they got the results. But we found out that that's not soon enough too. So then we tried to go a couple of days further upstream to whenever the patients are getting tested, if they can let us know. And we found out that that's not early enough either. So we instructed our case managers to inform us whenever you have a symptomatic patient that might get tested, then you flag us and we'll get the PPE out to the homes. And that made a big difference, I think. So when you have an outbreak in a foster home with 3 ICF patients in a crowded home, sometimes a dozen or more people, one day makes a big difference. So going upstream was probably the biggest thing. The second thing we learned was that you have to differentiate maintenance versus outbreak go kits. So the first batch of PPE we got to state, we got 10,000 surgical masks, and we divided that by 1,000 foster homes on Oahu. And each foster home literally got a Ziploc bag of 10 surgical masks, and that was gone within a week. So we didn't think that was a good use of PPE supply. We told the foster home, just keep using your cloth mask. And then we saved up for our PPE and we made go kits for outbreaks or symptomatic homes. So having these kind of as needed kits available was really helpful, as opposed to just getting maintenance out, which wasn't that helpful. That's the second point, maintenance versus outbreak kits. The third point that we learned is you really need a mechanism for real-time distribution. Having the PPE at our office in Kapolei was not helpful. We really needed to get it to the case manager's offices closer to the homes. And you have to be able to deliver it within hours, a couple hours. So that took a while, but that's been really helpful. The fourth thing we learned is you really need user-friendly instructions. So these are Medicaid homes, typically nurses aid run, maybe English second language, that has a lot of confusion with PPE instructions. And I'll give you one example. Well, one home we dropped off PPE at, there were more than a dozen true case residents in a small 2-bedroom home. They were all in the common area walking around. And when I dropped off the PPE kits, I could just picture them dumping it on the table, everybody touching it, including the COVID patients, everything's contaminated. So we really had to give specific instructions like how to open it, how to touch it, how to use it. We also found out that some families were throwing away the surgical mask every time they walked out of the room. Sometimes they were touching the mask with the gloves. So really, really basic instructions were really helpful. The other thing that's really helpful is to have the case managers as a resource for questions, because there's tons of questions. So we have the RN case managers for the foster homes as a resource. The last item that we didn't solve yet is how to get tested testing into the home. If you go upstream and you get PPE into the homes, then the home's going to call you and say, when can we get tested? And we haven't figured out that piece yet, but those are the 6 lessons learned for the fosters.
Great. Audrey?
Yeah, so hi, this is Audrey Suda Nakagawa. I'm with AARP, and you might be wondering, why is AARP involved in this? We were alerted to the situation that was being faced by not only our foster family care homes, but also our ARCHs, our adult residential care homes. And so what Dr. Toma didn't mention, that there's another additional 433 ARCHs statewide who are taking care of our seniors. And so collectively, between the ARCHs, the foster family care homes, and our assisted living, we're talking about over 8,000 residents that are in these type of smaller mom and pop type of organizations. Of course, the assisted livings are much bigger, but we were really concerned because we realized that, being a smaller operation, they really didn't have the kind of advantages like the larger nursing homes, the larger assisted livings facilities, who have access to more resource, more staff. They have the assistance of the HAH to provide all these type of information to them. So these individual homes were really doing it on their own with much help as they can get, but nevertheless, you could see all the challenges that Dr. Toma had engaged. So for AARP, we wanted to bring this attention to the Department of Health, as well as to the governor's office, especially to make sure that these individuals who are really the backbone of our long-term care system are also involved and are able to access PPE, as well as getting the kind of guidance that's very more specific to their operations. So, all this wealth of information that's coming from CDC is really great, but a lot of them are applying to the larger nursing homes, and to have it drilled down to the very nitty-gritty operational type of instructions that's very easy, user-friendly to understand, is something that was still needed. So as a result of that, of course, AARP is an advocacy organization, and so we did go to bat with the legislature to make sure that part of that $100 million allocation was going to be including organizations like the care home and the foster family care homes and the adult care homes. And then when we looked at the protocols, there was some information that was brought out from Department of Health, but we knew, again, we needed to synthesize that even further. So we have a small collective group of private and public stakeholders who are really rolling up their sleeves, and we are trying to synthesize those information to make it very user-friendly for all of these care homes, foster family, as well as the ARCHs. And so we're working on that right now as we speak. And we hope to have that ready for them. And so that they can just put it in a binder and really look at it. Oh, this is what it means about new admissions. Oh, this is what it means about transporting somebody who doesn't have to go to the hospital, but they need to go to dialysis. Who do you call? Which transport agencies are going to be willing to take a patient who has COVID, for example, not sick enough to be in the hospital, but needs to have care? So these are the kind of things that we are right now involved in. So I know that Dr. Toma talked about testing, and this is, again, a real big concern for us, because as you can imagine, in a residential or care home or foster family setting, we don't just have the caregiver, we have their whole family. We have children, we have spouses who go out to work. There are people going in and out of the house, and this is what Dr. Yazawa always calls the Trojan horse. And so it is really important that all the measures, all the safeguards are employed into these type of facilities, and they're really knowing what the best practices is. As of this week, AARP, the Executive Office on Aging, and some of the AAAs are in conversation with the federal administration of community living. They have come in part of with the CRAFT team that's here for the surge testing. And we have had put together a proposal to them in figuring out how can we try to accommodate the care homes. I mean, we cannot expect them to go stand in line or be in the cars at H3, for that length of time. And so can there be a different kind of surge testing for them exclusively? So this is really preliminary that we're in the talks with. And so, this is where we're at right now. So we really want to make sure that this group of providers are also well taken care of, because we understand the vulnerability of that. And if there should be a really massive outbreak, we can imagine the impact this will have on the healthcare system. So that's basically what we've been doing up to now. Any questions?
All right. Well, thanks so much for all your work and the summary. Thanks, Curtis, and thanks, Audrey. And I know there's a lot of people working on this as well. There's a lot of lessons to be learned on both sides. And obviously, it's the same type of population that we have in the nursing homes, as well as the care homes. And that, I would venture to say, the same sort of stuff that we're implementing in the nursing homes can be translated over, like even the checklists and the core competencies, and even testing strategies. So, it's just got to be found a different format to do that. So, so I'm really glad that there are lots of these efforts going on. Okay, so I'm going to ask a question, and I don't know the answer to this. I don't know if anybody knows how, with regards to, I understand, if you're testing for positive patients, but if you're doing the point prevalence testing, who writes those orders? Is it physicians do those orders, or who does those orders? I mean, are those automatic for facilities? I mean, as a medical director, I'm just kind of curious. Do we know?
So, Dr. Nguyen, I can answer that question a little bit. I do know that other states, they're generally doing standing orders for residents, person to these guidelines. Again, person to this new mandate that just came out. That's also been consistently done for other state mandates where they've already been conducting either weekly or monthly testing.
And Patrick, I had also heard that the Medicaid CMS requirements were saying under the CMS rule you could perform the initial test without a physician's order, but any repeat testing would require a physician's order. So if you needed to, on one occasion, run a test, it would not necessarily require an order. I'm just not sure on what the documentation process for that would be, or how the regulatory component of that would happen.
No, thank you for raising that, Dr. Campbell. It's absolutely correct. That's for Medicare beneficiaries, their first test does not need a physician or practitioner order, but subsequent tests do need some type of documentation and do need an order to verify that or confirm that. Thanks for raising that.
So this is Keith Ridley. In the memo that came out from CMS last week, the interim final rule, on page 6. Whoops, where did it go? There is a statement on ordering the tests, conducting testing. In accordance with 42 CFR, et cetera, the facility must obtain an order from a physician, physician assistant, nurse practitioner, or clinical nurse specialist in accordance with state law, including scope of practice laws, et cetera. So there is information in one of these memos on conducting the test and where orders are from.
Aida, this is Nicole Apoliona. We did our point prevalence test last week. Most of our long-term care is on paper charts. So I just wrote an order that we photocopied and I signed 100 of them and put the patient stickers on them. And then in our EMR, the nurse put it as a verbal order for me, and then I could sign off on it in my in-basket later. And that's mostly what we did for staff. Our staff testing was through our EMR, and the nurse put it in as verbal order, and I signed it off.
Okay.
I don't know how they would report. Who would they report the results to if there wasn't an ordering physician? Is my question. It might not be required by Medicare, but it is required by clinical practice and reporting channels, I think.
Yeah, I think we need to have clarification regarding those testing order requirements and who follows up on those orders, who's liable for following up on those orders, and how many hundreds and hundreds of orders do physicians need to sign off on every week for this as well, and the logistics of that, as not to even mention who pays for the testing, who reimburses for that. And I think those are real questions that we need to ask of.
Yeah, we've been doing standing orders. I've been signing standing orders for these weekly tests, and the testing does fall under, for at least for the three places where I'm the medical director. I've been the physician that's been ordering it, and it'll all fall under my name.
I can also cover testing costs as well. Generally speaking, insurance will not cover cost of testing in general health surveillance situations where there's no epidemiological clinical indication of disease. The exception to that rule is that Medicare will cover Medicare beneficiaries testing and nursing home settings as part of these testing mandate. That being said, for Medicare Part A SNF patients, facilities would generally still have to assume those costs under the per diem rate. But yeah, and this is getting to what Keith really mentioned on the call. We recognize that this will be a costly effort. But the Department of Health and Human Services has issued some relief funds to help skilled nursing facilities support these testing costs. But again, being that this is going to be with us for a while, we do expect this to get very expensive very quickly, which, as Keith mentioned earlier, we are working on identifying any potential solutions there that are available.
You know, hey, Patrick, if they are antigen positive, though, on the screening, if you do a follow-up PCR, I would imagine that would be covered, wouldn't it?
That's correct. So again, when it's clinically indicated in those situations due to exposure or due to symptomology, those would generally be covered by insurance, again, assuming that there's a physician ordering a test.
I think my biggest concern is that apparently these machines have a relatively high false negative rate. And so in an asymptomatic population, you know, you won't really know who's positive, I guess. I guess these antigen tests, like Dr. Kimball had said in the past, work better when you've got a large symptomatic group, maybe like in a cluster or something like that, but less so in this asymptomatic point prevalence type of testing. Is that true?
I think it depends to some degree on the test characteristics of the specific test that you got. If the test can be relied on for the positives, so if the specificity is and you're not going to get false positives, then I think you can have a clearer approach of how to use it, because at least if you know you're not going to get a false positive, that a positive can be trusted, then you know how to interpret it in different settings. So it's easiest to interpret when you're testing symptomatic people or people who you know were exposed to a COVID case. So if you have a case in your facility and then you test everyone on that unit, they're already at higher risk to convert to positive, and so you can believe your positive result. The problem is going to be you might, if you're just doing a sweep testing of all staff with those antigen tests, you're going to have slightly lower sensitivity. You may miss a couple people who might actually be positive. On the flip side of that, it depends on who is it actually detecting. Is it detecting people that have a lot of virus that they're actively shedding and are really infectious, or is it detecting people who maybe had virus a few weeks ago and are no longer actively shedding? And if it's missing those people that were infectious a few weeks ago, that's not really a problem, right? Because what you really want to pick up is the highly infectious people. So you could see a strategy where if you're testing weekly, at least you'll pick up when somebody does convert, and you might not pick them up on that first round, but you might pick them up on round 2. I think that's part of the logic probably for the twice weekly testing if you have really community prevalence above 10%, or excuse me, percent positivity above 10%. But I think it is going to be a learning experience, and we're already hearing from Dr. Wen and some of the colleagues she's reached out to in other areas. They've experienced some issues with trying to use the tests in this way as a mass screening tool. So the use case is really clear for symptomatic people and people who were definitely exposed. It's a little fuzzier for the mass testing approach.
Yeah, those are the main issues that AMDA is bringing up to national thing. I saw over here about the weekly testing required. Okay, for point prevalence testing, only applies to staff, not for residents. And then the comment about the saliva test is from reports on the mainland. It is a pretty low sensitivity, and the problem they thought was a high rate of false positives, which resulted in lots of staff and being put out of work, and then patients being quarantined only to find out with follow-up PCR testing that they're all negative. And so the consequences to that are very real, not to mention that older adults don't produce a lot of saliva. That's one of their problems. And so that's why I think that's particularly problematic for our older population, nursing home population.
The testing environment is just changing so rapidly right now that we continue to hear about new test types coming out every week and new approvals. So I think as experience grows with certain test types, we may find ones that are quite useful for these settings. I think just right now, it's still a bit of an open playing field, and we're going to have to feel our way through it.
Okay, well, anyway, time is up. Sorry, guys. There's always more, and I wish I could stay on. But anyway, I want to say thank you. There is an evaluation form. Please go back, just scroll up on the chat box, click on that, do the evaluation form right away. You can get your CMEs, CEs, and yeah, come back with questions, and maybe we can address them next time when we talk about death certificates, right? Okay, thanks everybody for joining us.